Hello again. I'm still from a general surgery resident from Walter Reed, and this is my project. So this was looking at predicting respiratory as well as venous thromboembolism complications in open abdomen patients. These patients are ones that we will see in the military surgical population. However, the patients that I'm referring to in this are based off of civilian level 1 trauma center data. Nothing to disclose. So damage control laparotomy can be used in a stage approach in patients and extremists, and something that we should be familiar with being deployed surgeons. And an open abdomen puts patients at risk for complications not only related to the wound, but also those that are related to critical care. So when you look at hospital-acquired pneumonia, it's one of the most common nosocomial infections that patients can get in the ICU, and up to 28% of mechanically vented patients can develop VAP, or ventilator-associated pneumonia. Venous thromboembolism, on the other hand, we do start DVT prophylaxis on most patients, and but up to 9.6% of patients within that population can still go on to develop a DVT or a PE. And then there are some studies that show there's a relationship between arterial and venous thrombosis and that of pneumonia. However, most of these are within non-trauma patients. So that was something that we wanted to look at as well, and to see if if you had pneumonia, if there was an increased risk of VTE from that. So the aims of this study were to characterize infectious respiratory and venous thrombotic complications in open abdomen patients, describe any similarities that we saw in clinical as well as biomarker data, and then develop predictive models for VTE and VAP. So we use the Tissue and Data Acquisition Protocol, also known as TDAP, and this is a prospectively collected repository of clinical data as well as biological specimens that maintained by the Surgical Critical Care Initiative that's based out of USHIS and works with our civilian colleagues at Duke and Emory. The inclusion criteria for this study was between patients that were seen at a level 1 trauma center from 2014 to 2017, and these are all adult patients, and they underwent an exploratory laparotomy after either blunt or penetrating abdominal trauma at a level 1 trauma center. So these are a list of the biomarkers that were included in these studies and clinical variables that were also included. Things that we looked at were injury severity, transfusions, other major injuries such as lower extremity fractures or pelvic fractures, patient complications. Again, this was looking at if they develop VAP or VTEs, and then patient comorbidities. So our model, what we wanted to do was use a machine learning algorithm, and random forest model with backward elimination is what we chose to use. The image that you see on the left is how random forest kind of thinks through and develops the model. And then if a variable was missing in greater than 45% of the, or was missing 45% of the data, that variable was excluded. And then we excluded patients, only included patients with complete data sets in what we were and doing the analysis for. The rest of the statistics were using the Crucial-Wallace and the chi-squared test. We had 390 open abdomen patients that were identified between that time period, but 11% of them developed hospital-acquired pneumonia, and then about 18% of them, of those patients who developed pneumonia, also developed VTE. This was not statistically significant in this case. And then about 7% of the total 390 patients developed VTE. Higher injury severities and the number of transfusions that these patients received were statistically likely for them to go on to develop VAP as well as VTE. And then both biomarkers of IL-1RA as well as IL-6 were significantly elevated in patients with VAP as well as patients with VTE. So from there, from the exclusions of complete variables as well as complete data points for those patients, we had 118 patients we were able to develop our model from. And again, these are the incidences of VTE and VAP in this patient population that we used. The median age for these patients were about 33 years old, and the majority of patients were male. So when we used our clinical and biomarker data to develop our VTE model, we had a pretty good model that, with an AUC of 0.86. We identified 4 features that were important for these patients, and that would include the total blood they received in the first 24 hours, the presence of a leg fracture, and then looking at the biomarkers, IL-6 and VEGF were all significant things within this model. We tried to see if we could exclude the biomarker data and just develop a model based on the clinical factors. However, as you can see, the AUC was much lower at 0.7, and they identified 3 factors of severe sepsis, VAP, and central line placement. However, as you can see, a lot of those features could be interrelated. Finally, we looked at clinical and biomarker data for VAP and also had a very high AUC of 0.9 and identified 4 features of Apache score, total blood in the first 24 hours, and then the 2 biomarkers that were previously mentioned. So just one thing to kind of note with all of this, these are all serum samples that were collected at the initial operation. So although patients develop these complications, 9 to 10 days out, all these factors that we collected were at the beginning. So it allows you to really predict which patients you have to watch for, and really what things that we need to think about are how do we deal with knowing that this patient is at high risk for developing a VTE or a VAP. So in conclusion, machine learning algorithms can be used to help predict VTE as well as VAP using clinical and biomarker data. And then biomarkers increase the performance of these models. But one thing we need to consider is that access to these tests might be hard for other hospitals if it wasn't in this study. And really the next step in all of this is doing internal and external validation of our model. This is a team that we worked with. And thank you. Any questions?